Welcome to Health Talks from the Inside Out. I'm Dr. Carrie Lind, and we're glad you're listening.
Dr. Carrie Lind, our Chief of Pediatrics here at Williamson Health. Thank you for joining me on the podcast today.
Thank you for having me. I'm happy to be here.
Good. So we like beginning these conversations by just asking you what drew you to medicine and how did you ultimately pick pediatrics as your specialty?
Let's see. I have wanted to be a pediatrician since I was a little girl. Okay. I think I started wanting to be a marine biologist at like age 2, and then I realized you had to live near an ocean to do that, and I would have to move away from my family. Right. So I pivoted and wanted to be a pediatrician probably since I was in kindergarten. Okay. And so my whole life, I knew that's what I wanted to do. My grandfather was a family doctor in a small town in West Tennessee called Milan, Tennessee.
Okay. Yes, I've heard of it. Yeah.
It's little, but and he took care of thousands of people there. He did surgery, he delivered babies, and I still occasionally run into someone who knew him or maybe he delivered this person. And so it's really fun to see how many lives he touched. And I knew I wanted to follow in his footsteps. I remember when I was a little girl and staying with them for a holiday, and he was getting ready to go to work early in the morning, and he would say, I've got to go. I'm going about my master's business. And he really did think of medicine as a calling, and I feel the same way. I feel like taking care of patients is a true privilege, and so I've always wanted to do this.
So you're a pediatrician by training and maybe by your first love, and then now you are practicing as a pediatric hospitalist here at Williamson Medical Center. So what are the differences between those two practices?
So I did pediatric residency for 3 years, and I am board certified as a pediatrician. And then depending on what subspecialty you want to go into, many pediatricians go on to do further training. Okay. So I'm a pediatric hospitalist. I'm also board certified in pediatric hospital medicine. Okay. And that means that I take care of children in the hospital setting.
So speaking of pediatric patients in the hospital, we just recently celebrated 10 years of pediatrics here by way of our partnership with Monroe Carell Jr. Children's Hospital Vanderbilt at Williamson Medical Center. So can you talk to us a little bit about that, the services we offer, why that's unique to the families here in Williamson County?
So as part of our pediatric services, we have a dedicated 8-bed pediatric emergency department with 2 trauma rooms ready to take care of patients from the community. We have a 10-bed inpatient pediatric unit. We have rooms that are equipped with negative pressure rooms to take care of certain infectious diseases. We have behavioral health rooms that are safe for our pediatric behavioral health patients. We also have dedicated pediatric ancillary staff, including a pediatric pharmacist, pediatric child life, a pediatric nurse educator, and a pediatric nurse manager. And all of the nurses that take care of patients in our pediatric unit are trained to take care of children.
Yeah. So not only are those units separate from the adults, we're talking about the pediatric emergency department and the inpatient unit. So they're completely separate from the adults, but then they're also staffed fully with pediatric trained providers and caregivers that know how to care for children's unique needs.
Yes, exactly. And the partnership between Monroe Carell Jr. Children's Hospital at Vanderbilt and Williamson Health has been so smooth, and the physicians and advanced practice providers in the pediatric emergency department and on the floor are all Vanderbilt employees. Yes. And then our pediatric nursing staff and many of the ancillary services are actually employed by Williamson. But the partnership there has just been incredible, and we all really feel like one big family at Williamson.
Yeah, I love that. So you mentioned child life specialists. Let's tell people what does that role do? I know we have a few different people that fill that role. What does a child life specialist do, and why is it so important to our pediatric patients and their families?
So we actually have 2 child life specialists on staff at Williamson. They are both wonderful people who work 5 days a week to help patients cope with the hospitalization process. So that can mean that if we've got a child who's very worried about having an IV placed, then Nancy will come and walk them through that. She even will show how an IV might be placed in their stuffed animal. She uses props for that, and she really makes that process much less scary for the patient. So our child life specialists really help the families in a situation that's very stressful to them, and to make this as comfortable and as safe as they can possibly feel.
Yeah. And let's talk about the spaces a little bit, because the spaces in our pediatric ED and the inpatient unit look different. So let's talk about the spaces we have, the processes we have that might be a little bit different than the adult side.
Yeah. I think if anybody has walked in the doors, they recognize that everything is geared toward a family experience. And so when you walk into the pediatric emergency department compared to the adult emergency department, the feel is supposed to be warm and safe, and you really feel that way walking in. So the pediatric emergency department rooms are fully equipped with top of the line technology. We have never had a situation where we requested a piece of equipment that we weren't able to get. So recently we requested to have a transcutaneous billimeter that we could use on our inpatient unit, because the nursery and NICU share one, and that is a machine where the nurse shines a light on the baby's head and it gives us the level of jaundice that the baby has.
Without having to prick. So no finger or toe pricks.
So yes. Before we were obtaining serum bilirubins with a heel stick and getting a blood drop to check the jaundice level. So you can understand how some babies were getting multiple of those sticks in their short stay in the nursery or NICU. And so this was a real wonderful thing to have in the NICU and nursery space. But when we requested it for the inpatient unit, the Williamson Health was happy to allow us to use that there, so that we can now actually obtain bilirubins for our inpatients, patients in the emergency department, and even more wonderfully for our community pediatricians who don't have this equipment in their office. So we have a great relationship with our outpatient providers so that they can send a baby in. We can what we call bop them to get a light on the head and get a level without hurting the baby. So it's really been just a wonderful commitment. So taking care of a pediatric patient in the hospital can sometimes be hard because they're scared, they're in pain. And so we have great equipment. We have staff that's very comfortable taking care of children to help ease the process through things like getting a CAT scan or getting an MRI or things like that can be very difficult for children.
So let's talk a little bit about when to bring your child to the emergency department. I know that sometimes parents are a little bit unsure sometimes. So, what are those kind of high level things where if you're experiencing this, absolutely bring them to the emergency department. We'll check them out and either send them home or admit them or get them to where they need to be?
Yeah, that's a tough question. And sometimes I'm on the fence. So don't feel bad if you're not sure. Yeah. First, I want to say that the pediatric emergency department at Williamson is open 24/7. So we're always here. If you have a question, please bring your child to the emergency department. I would never want to say don't come because it's available to you at any time. But some parents prefer not to come to the emergency department if they don't have to, and that's totally understandable. Things that absolutely, to me, require emergency room care, and it's probably best to start with the emergency department rather than go to your pediatrician's office or to an urgent care, are things like respiratory distress. So if you've got a child who is breathing hard, breathing fast, you're noticing retractions at the neck or the chest wall where it's sort of pulling in. They have a pale color to their face or blue to their lips. Those are absolute emergencies, and you need to be seen right away. And we do sometimes see that here in the wintertime, especially with RSV or flu. We see pneumonia and bronchiolitis or asthma attacks, those kinds of things that really do require emergent care. And if you're ever worried, please call 911 and the ambulance can start the process of treatment right away. In addition to that, altered mental status. So if you have a child who's confused or not speaking the way that they should, or having trouble walking, if they're very sleepy, lethargic, bring them into the emergency department. It may be something simple, but I think it's best for us to see them first. These are also things that if you do bring your child to urgent care, they're probably going to send you to us anyway, so it'll save you a step. There are certain populations in pediatrics that we are a little more careful with, and you may want to wait to see your pediatrician, but we take these patients a little more seriously right off the bat. So a baby that's under 30 days old, really pretty much anything that's unusual, we like to see them pretty quickly. So things like fever over 100.4, a low temperature less than 97 degrees. Not feeding well can even be a sign of infection or something wrong with their abdomen. If they're vomiting, if they're lethargic, or if they're crying and you can't get them to stop, those are all reasons to come to the emergency department.
Okay.
Injuries are tough, I would say, and a lot of people want to know which ones to come to the emergency department. There are great resources in the community for a lot of injuries, but if you have a child who's got an obviously displaced break in their bone, meaning that it's angled or visibly not
breaking
aligned.
through the skin.
Exactly.
Right.
Skin.
Yeah.
Those are probably best seen in the emergency department. One, we can provide pain control pretty quickly, and we can sedate to put them into a mild state of sleep for a procedure.
Right.
Lacerations. So a lot of people want to know if they need stitches. I get texts on my phone.
Right, all the time.
With a picture of a cut asking, does this need stitches? So that's a tough one. And if you are on the fence about it, urgent care may be the place to start, because sometimes gluing a laceration like that is the best option. And they do have that ability at urgent care or sometimes at the pediatrician's office. But if it's multiple lacerations or it's very deep, we're probably the place to start is the emergency department.
Right.
There are very few things that we can't take care of at Williamson in the emergency department. And if for some reason it is a case that needs to go downtown to Vanderbilt Children's for more subspecialty care, or because it's a level 1 trauma or something like that, we see those every once in a while, and we have a great process in place to transfer. Yeah. The good thing about showing up here at Williamson, if you have a problem, is that we can figure that out quickly.
Right.
And so I think some parents feel like they should make that choice by themselves, but we're happy to help with that information when the patient arrives.
Yeah.
We also take a lot of calls from pediatric offices or providers saying, should we send this patient to Williamson? So we have this question a lot, and we're happy to take any patients to help figure that out.
That's good. And we hear so much positive feedback and praise about our pediatrics from the emergency department and also the inpatient unit. And one thing that we routinely hear is people are so amazed and surprised at how quickly they usually get seen.
Yes.
And I know it depends on the day and the time of day, but usually patients are seen relatively quickly.
That's so true. I brought my children here before as well, and the wait time is very rarely long at all. And sometimes there are certain hours of the day that if it's going to be busy, it tends to be between 6 and 10 p.m. or something like that. But but even those hours, we generally don't have a long wait.
Right. So obviously, taking care of pediatric patients is different than taking care of adult patients. What are some of the interesting facts or things you'd like people to know that are different taking care of children versus adults?
Yeah. Well, I think they're more fun.
Yes.
First of all, no, I'm just kidding. But I think taking care of pediatric patients in general, we're dealing with a healthier population. And that's part of what makes my job so enjoyable, because my goal is always to get the patient back to where they were when they came in. So kids just in general are very resilient, and so usually they're healthy and they get back to kind of their old activities very quickly, even with serious infections. So, but there are some medical differences between a child and an adult. One thing we tend to see is if a child is sick, they sort of hang on a little bit longer. Adults tend to show that they're ill pretty quickly.
Okay.
And that's because their bodies are so strong, they
Yeah.
can kind of handle pretty serious illness until the point where they can't anymore.
Right.
And so that's what we'll sometimes see with things like RSV. A child will be just drinking their bottle, they'll be hanging, hanging in there, breathing hard for a couple of days, and then they sort of tire out. And so that's a time where they may need support from us to help maintain their respiratory status. We also notice that with severe bacterial infections that adults may come in with a low blood pressure in a situation where they're septic, and a child may just have sort of a higher heart rate and their blood pressure is normal until the point where they kind of can't maintain that anymore. And so that's one difference. The other thing we tend to think about is just their brain development. Pre-pubertal children, their brains are not fully developed, and we know that probably from having children
yes.
just on our own.
Right.
But for things like injuries, so concussions, or it just kind of reinforces the importance of making sure we're being really safe with helmets on bikes, because injuries to the brain before development can be more severe and more dangerous than an injury to the brain later in life.
Right. That's good to know. And going back to what you said previously about kind of like their little bodies can almost weather the storm a little bit stronger until there's a drop off. It just reinforces with me the importance of when you do start noticing something doesn't seem right or it seems off, go ahead and bring them in, because chances are it is something that needs to be looked at.
Yes, I think that's a great point. And sometimes children don't show very obvious signs that they're ill. And it's one reason why when a child's under 30 days and really probably even 2 months, you just need to take even little signs.
Right.
They skipped a bottle. They aren't waking up as easily from a nap. Those kinds of things can be a sign that there's something really serious going on.
And I always want to make sure that the community is hearing us say we are never bothered by somebody coming in. We want you to come in. So if you're a new mom and you have any kind of question with that new little baby, bring them in. Definitely. And we'll love on them and get it taken care of.
Yeah. And I personally brought my 5-year-old to the Williamson Emergency Department a few months ago with some vomiting and abdominal pain, and I just wasn't sure. I had this feeling that maybe there was something more serious going on because it had just been kind of an unusual course, and I felt so comforted myself by the pediatric emergency department's care for her, and it turned out everything was fine. So.
Right. That's so good for the rest of us. I was going to say, that's so good for the rest of us to hear that even a pediatrician, you take care of patients every single day as a pediatric hospitalist. Sometimes you're not sure. Right. And you want somebody else to look and speak into it. Thank you for sharing that with us. Okay, so you mentioned how fun pediatric patients are. I want to know how funny they are. So is there a funny moment or saying that you can remember a patient saying or doing that was just so funny?
Yes, they are. They're just hilarious. And we all know kids kind of say things that are funny all the time. But recently I had a patient who you go in a room and you kind of find out right away how they feel about you as a medical provider, whether it's based on experience or age or what. But I had a child who wasn't giving me much back. She was watching Doc McStuffins on her iPad. And so that was a show my 5-year-old loved. And so I know that whole theme song. So I started singing it, and she looked at me with a glare that would, just freeze you.
What are you doing?
And I said, no.
Yeah.
I said, okay.
Oh my God, put you in your place, doctor. Yes.
So sometimes you win and sometimes
so they're very honest. Yes, I can imagine
very,
they're the most
honest
patient population that we have.
They are.
And likewise, is there a time you remember some real creative way you had to explain something? Like, I assume you can't use your complex knowledge and terminology when talking to a patient.
Yes, I think that is really a big part of pediatrics is figuring out how to explain things to patients. And I think it's made me a better doctor and a better person at explaining medical things to adults as well who are not medical, because it's really not necessary to use big language to talk about procedures or diseases. And so I think it's made it easier for me to communicate with everyone, learning how to talk to children about healthcare and their own health. And even my own children, though they get a little tired of me sometimes talking about medical things. One day, my daughter, she's 12 now, and she she was up in the room and she was playing with a pair of magnets, and I was saying goodnight to her, and she was sitting in her bed and she had a pair of magnets, and I just said, Lucy, a pair of magnets can, if you swallow them, they can, they can connect and they can tear a hole in your esophagus, and she was like, Mom, do you think the magnets are just gonna find their way into my mouth and destroy me from the inside? And I thought, okay, maybe that's a little.
They're gonna jump in my mouth when I'm sleeping. Yeah.
Oh, so I do think it's hard to shut it down, but I think.
But you've seen so much, too much, probably.
That's true. A lot of the things like that I've seen.
Yeah. Are there any misconceptions about pediatric patients or pediatric care that you want to dispel or?
I think that this time in healthcare is an interesting time to be a provider, because sometimes the media or the political landscape makes us all feel like there's, two sides to the coin. Are you pro-vaccine? Are you anti-vaccine? Are you pro-medication or anti-medication? And I think that there's, I think as a pediatrician, as a pediatric hospitalist, I love to have conversations with families. I think that medicine is a little bit more of an art than a science at times. So when a family comes to me and says, I have thoughts about how I want this to be handled, or I have thoughts about how I feel about certain medications or certain treatment plans, I love to talk about that. I think we can learn from each other. There's not always a right way to do things, and sometimes different families prefer different techniques on how to cure a disease or to handle a situation. And so I really think that one misconception is that pediatricians don't want to hear what your thoughts are about your own health care. So
it just speaks to kind of our overall philosophy of we want the care to be a partnership or a collaboration between providers and the patients and the family members.
Exactly.
So that's good. Okay, we're coming into not only the holiday season here in a few weeks, but also flu and cold season. What are some tips to keep our children safe during these times?
I mean, my children are in public school, and they have had a cold, I feel like, since September 1st. I know it from personal experience how much it's out there. I think one thing to keep in mind is that a lot of respiratory infections are actually transmitted by contact rather than droplets. I think we hear about flu and we hear about COVID, and we think the infection, the virus is in the air, and if somebody coughs 3 feet away from me, I'm going to get sick. But RSV, for example, is transmitted by contact. So if you can really do a great job hand washing or using hand sanitizer in a classroom or at your own home, then that's a great way to prevent transmission from patient to patient. And the flu vaccine, this year the flu is supposed to be brutal. We haven't seen much of it yet, but I know it's coming. And so you still have time to get your flu vaccine if you're interested in that. And I especially recommend that for families who have children with underlying immune problems or with asthma, because they're especially at risk for more severe flu cases.
And what about just some of those general tips too about, I know that we're coming to the holidays, there's going to be lots of treats and there's going to be lots of exciting, maybe late night activities. But what about sleep and healthy eating and that type of thing?
Yes, I think just making sure that they're catching up on sleep if they're having some late nights, and try to limit the sweets if you can to sort of special occasions. So we're pretty bad on Christmas morning with stockings and that.
I know.
But we try to have a fairly normal dinner that night. And so just kind of counterbalancing the fun with the health.
Everything in moderation.
Exactly.
Lots more fun at this time, but we'll balance that. We're good. Okay, I like to ask people, is there a particular patient or family that has just really stuck with you?
Yes, there was a family who I actually saw at Williamson probably 5 years or so now. It was a baby that was under 30 days old who came in with poor feeding, probably why I'm so mentioning poor feeding a lot. But this patient came in, and mom said that he had had a couple of feeds that didn't go as they normally did. And so in the emergency department, he did not take his bottle well, and we really didn't know what was going on at the time. The pediatric emergency doctor just said, maybe he's getting sick with something, but I'd like to admit him on some IV fluid so he doesn't get dehydrated and just see what happens. And so through that evening, we noticed that his feeding seemed more and more uncoordinated, where he was unable to kind of latch onto the bottle and suck at the same time. And after kind of taking some history from mom, we sort of decided that we thought he might have been exposed to botulism. And so the crazy thing about botulism is if you suspect it, you have to call a specific health department in California where they make the antidote, and you have to have it shipped.
Oh my goodness. Okay.
At a very high cost by plane.
Right.
So I had to make a commitment to that diagnosis, and we transferred this little sweet baby and this family. And I'll tell you, it was a late night out at the hospital, and she was crying and I was crying. It was right around the holidays. Yeah. And we sent him to Vanderbilt where the antidote was delivered, and he got the antidote right away because the testing takes weeks to come back. Wow. And when it finally came back several weeks later, it was truly botulism. Wow.
So you gave the antidote before you all had
if you don't give it right when you suspect it, then they can it can move on to respiratory depression and needing a breathing tube. So he did great, and the family came back about a year later around Christmas time and brought me flowers and a thank you note because we were loading him up in an incubator, and it was just very traumatizing for everyone. But I had enough of a suspicion that I felt like it was the right thing to do. So that's one example of a family that really stuck with me. And I have countless cases like that where I think really being with a family in a time that they're most vulnerable and things are most scary really bonds you in a way that not many other things do.
And those memories stick with you, and I have no doubt they stick with those families too. You know, you will forever be part of their story. And as I'm sitting here talking with you, I'm just so in awe of you and your colleagues, everybody that takes care of our pediatric patients. You know, the babies, the children often can't they can't talk. They can't explain to you what they're feeling and what's hurting and what's going on. And I'm so amazed that y'all can figure out what that is and care for those patients. So thank you. We're all so grateful to all of you.
We're grateful to be here.
Yeah. Okay, so last question. What do you think, and we might have kind of already hit on it with that last story, but what would you say is the most rewarding part of your job?
I think as a pediatric hospitalist, the most rewarding part of my job is seeing a patient when they're very sick and getting them back to walking out the door ready to get back to sports or school or whatever makes them happy. And so I feel rewarded by being part of that process from the beginning to the end. And it is really still what drives me today to continue to do this. Yeah.
Well, Dr. Lind, thank you so much for being with me today, coming and sitting down. I'm so excited for our community members to continue learning about all the different pediatric services we have here at Williamson.
Well, thank you. Appreciate it.